Hi, I'm Diane Lim. I'm Director of Outreach and Senior Advisor here at the Penn Wharton Budget Model, and I'm here today with my colleague Felix Reichling. We're talking about our recent analyses of Medicare expansion policies. They're commonly referred to as Medicare for All. And I'm happy that you could join me today to talk about your work.
Thanks for having me.
So, first of all, you've done a couple different analyses. The first one was designed to be a more general look at expanding Medicare, and the follow-on a little bit more specific. Can you tell us first about the general or stylized analysis that we did?
For that analysis, we assumed that that Medicare, as it currently exists under current law, would be expanded to the entire population. So everybody would be covered under it.
Not just retirement age.
That's right. And benefits wouldn't really change from what retirees currently receive. And then we analyze how different financing options, and those are deficit financing, payroll tax financing, and premium financing, would affect the health of the population, the federal budget, and the economy.
So why is there so much attention from politicians and policymakers on this idea of expanding Medicare?
Well, the main point is pretty straightforward. To increase access to healthcare and to decrease costs of the healthcare system. There's ample evidence that the United States has very high administrative costs compared to other countries, and Medicare for All would bring down those costs. And because people would have better access to healthcare, they would be healthier and also more productive over time. We also spend a long time estimating from data how people make choices about healthcare and how their health changes over time. Our model is unique in the literature in that it lets people choose to forego healthcare altogether. All of this detailed modeling of healthcare decisions and insurance is integrated into a larger macroeconomic model. One big integrated model of the macroeconomy.
Okay. So I know that it's very complicated, and so we don't have time to talk about all the details here today. And you've highlighted some of the main connections. Why this integration of those household level healthcare decisions with the government programs, how they affect those decisions, building up to the macroeconomy. Has anyone else done that before within one integrated model?
No, we are the first ones to do that. People's decisions about their healthcare choices and labor supply choices are intimately tied, and those also depend on wages in the economy. Analyzing healthcare choices separately from the effects of the economy and government policies on people's financial situations would be at best misleading, maybe.
So a big part of the analysis had to do with how you pay for those expanded benefits, right? And at Penn Wharton Budget Model, we commonly come out with analyses that emphasize that deficit financing is sort of a losing proposition when it comes to macroeconomic long-term supply side growth of the economy. And we do have that deficit financing option there. But we also have two other options in the analysis. There's raising the revenue to pay for the program with higher payroll taxes, but then there's another option that we call premium financing. Could you tell us a little bit more about those two financing options and why they result in different economic results?
The payroll tax is a certain percentage of each paycheck that goes straight to Medicare. It's proportional to your wage, whereas the premium is a flat fee that's the same for everyone. Now, under the payroll tax scenario, since you're taxing wages, people have less of an incentive to work because their take-home pay is lower. The reduction in labor is partially offset by the benefit that I mentioned earlier, a healthier, more productive, and larger workforce. But overall, the economy shrinks when the supply of labor decreases by about 3% over the next 40 years. Under the premium scenario, there's no disincentive to work. Everybody pays the same premium. Still, workers are paying Medicare premiums that are lower than their private insurance premiums are currently. And so they work more and save more. Rather than shrinking the economy, GDP will be roughly 15% greater than it would be under current law.
In policy discussions, we often hear people talk about GDP effects as if it's a proxy for well-being or welfare.
Yeah.
What have you found in terms of the effect of these Medicare for All programs on well-being or welfare?
We are still working on the welfare calculations. However, GDP is not a good measure of welfare. Welfare includes having more predictable household finances and better insurance against large losses. Better access to health insurance means that the average person might still be better off, even if in scenarios that reduce GDP.
Right. I mean, one of the main results of the general analysis and your more specific analyses is that it does improve health outcomes,
Yes.
right? So that's a big thing that isn't captured in our GDP measurement, except as it contributes to higher income.
Yes,
right?
that's correct.
Good. Well, thanks, Felix, for talking about our analysis of Medicare for All.
Well, thanks for having me.